That's helpful. And I gather that we're being live streamed as well, as recorded. So that's just very helpful to know where people are and where they sit. Good. And is anybody, I'm not going to ask you to put it in the chat because that's a difficult one, but I wonder if any of you feel that you're actually somehow involved in something like euthanasia or around euthanasia, and what really, in a way, what you feel about it. And I think one of the difficulties that many people have had is that since we've had COVID, things have become quite hard for many clinicians. And so the pressures on us as clinicians have increased greatly since COVID's come along, and made things much more difficult for everybody. So I'm going to try in a moment now just to share my screen with you and run through some of the things around difficult end-of-life decisions that occur. So if I can do this, I hope I can. I hope this works. And you should now, I hope, and perhaps somebody could tell me if you actually can see my slides that are on the screen.
Yes, it is visible.
Good, thank you. Okay. So when we're thinking about people at the end of life and who are dying, I think it's worth remembering what Cicely Saunders said, which is the way that people die lives on in the memory of those left behind. So what happens today affects tomorrow's generation. And people think about end of life decisions, but I would just remind you that as the green arrows show, you take lots and lots of decisions with patients all the time. And sometimes you look back and you think, oh, we should have taken a different decision, perhaps. Sometimes you think, well, it turned out to be futile to try a treatment. At the time that you took it, you thought it would be the best thing. So it's easy to look backwards and be critical of our own decisions. But I think it's also important to be aware that in every encounter that we have with a patient, we're often taking many decisions, not even just one decision, but lots of different decisions are being weighed up. There are different legal frameworks. I've just put these up because they're ones that affect the way that we manage patients in the UK. I don't want to spend time on this, but I think it's worth you thinking about the legal framework in which your health and social care systems are delivered, how that puts pressure on you, whether you have a Mental Capacity Act, and I will say a bit about mental capacity, and then what the law in your country is about assisting suicide, and linked to that, of course, about euthanasia. And also how you as a profession are regulated. And I will say a bit about double effect, because I think it's very misunderstood. So what about double effect? Well, some people say, but you are hiding behind double effect. Your double effect is not really double effect. You are actually killing patients with morphine or similar drugs. I want to explain to you why that's a complete fallacy. This is not what we're doing at all. Whenever you give a drug, you know that there may be side effects. You know that there may be a problem, but that isn't unintended harm. You don't intend it, but you know that it might happen. So if you think about chemotherapy as an easier example, you know that the person might become neutropenic, and indeed they might become septic and they die, but that's not what you intend. You intend to decrease the malignant cell count. The nature of the act is good. You're wanting to decrease the amount of malignancy there. The intention is for the good effect, to get on top of the cancer, not the bad effect of sepsis and death. And on balance, in that situation, the good effect outweighs the bad, and the situation is sufficiently grave to merit the risk of the bad effect. And the other thing that's important is you don't have to go through the bad effect to have the good effect. So if we think about morphine titration, you plan to get on top of the pain. You do not have to get into the zone of toxicity. You do not have to have respiratory depression in order to get on top of pain. You may have to give breakthrough doses. Your intention is to get on top of the pain. There may be times when the dose is calculated wrongly, and some patients do get some respiratory depression, in which case you decrease the dose back again. There may be times when the breakthrough dose is inadequate, so you have to give another one. If that person, because they've got a slightly depressed respiration and a depressed cough, then gets a pneumonia and dies, you haven't killed the patient. You didn't intend that. You didn't intend to depress respiration. Your intention and the way that you managed the drug was to get on top of the pain. So I hope that you can see that double effect is not killing patients behind the scenes at all, but the explanation was there on the earlier slide. Now, we did have a mass murderer in the UK called Harold Shipman, and he deliberately gave massive overdoses of drugs, but that was murder. That was not double effect. What about if we're going to stop an intervention? What are we intending to do? Well, we intend to do good, i.e., the burden of the intervention is greater than the benefit. We do not intend harm to the person. We do not carry on with something which is distressing somebody and has no therapeutic benefit. If we stop it, the person might die quite quickly. If they do, you must provide all care in the time from when you withdraw the intervention until death. It may be that death is quite a long way off. You stop the intervention, such as, for example, ventilating somebody, but they start breathing spontaneously. You provide all care and they die much later, perhaps weeks later, perhaps months later, or perhaps you find that they don't die and they improve. That is completely different to euthanasia. In euthanasia, you're giving a drug deliberately to bring about death as quickly as possible. And it is a long time before death would have otherwise occurred. So again, I want you to be clear. What we're talking about is giving massive doses of lethal drugs. This is not about managing the withdrawal or cessation of treatment. What about the person who says, I just want to die, I don't want to go on? Well, when we look at the data from Oregon as to why people fear the future more than today, you would expect pain to come at the top of the list, but actually it doesn't. The data from Oregon shows that top of the list are things around not being able to enjoy oneself as much, fear of being a burden. 57% of people said an end-of-life concern. These are people who went on to have assisted suicide. Their concern was being a burden. And other things relate to loss of control, fear of losing their dignity. Of course, people are often frightened that they will go out of their mind or whatever, but they're frightened of things which are just not going to happen to them. So fear is a potent driver to despair, and feeling that you don't have a role, that you're not wanted, that you're a burden fuels that. Now let's think for a moment about how we all make decisions. Our own experience and our memory are very powerful influences on our decisions. I said the way that a person dies lives on in the memory of those left behind. Those memories influence hugely the way people make decisions. Those feelings that they have from people around, that they're a burden, that they're a nuisance, that their doctor feels hopeless about them. All of those are major influences on decision making. And of course, people get information from the media, and they pick up non-verbal signals, particularly the reactions of their family and of doctors around them. Actually, we think that we give patients formal information, but it has a much less powerful influence than those feelings and memories that people store up in their hearts. And what about this word dignity? Well, Cicely Saunders said dignity is having a sense of personal worth. Dignity isn't whether or not you're continent, whether you can feed yourself unaided. Dignity is how people behave towards you. It's whether people treat you as if you are a lesser being, as if you are of no value, or whether they treat you with sympathy and empathy and recognize that even though you may have problems with continence, even though you need help with eating or with drinking, you are important, you are a precious person. They want to look after you, they want to support you. And also that you are important to them in their lives. You still have a role in life. And Harvey Chochinov has shown that the way that care is given can increase somebody's sense of personal worth and dignity, or if it's not given in a good, warm way, it can undermine them and make them feel that they're useless. So just remember, in any consultation or in any situation, the way that care is given steers that discussion. The way that you behave, and I've likened it to sitting on a tandem. The person at the front is the one who holds the steering bar, can steer the conversation. That one on the front is usually the doctor, but it may be a senior member in the family. And the patient is behind, frightened, not sure where they're going, not sure what's happening. So the way that you steer it and the power that you have over the patient in front of you should not be underestimated. That power differential is important and is potentially dangerous. So what about the person who says, I just want to go on? I hope that you'd all listen and reflect and possibly say, so you really want to die? What's behind that? What's the reason? But if you process that as a straightforward request, you give the message that you think the person is right, that they'd be better off dead. If you ask them, what is making today so terrible? What can I do to improve today? How can we manage things? You give the message that you are worth me working hard to improve things. And indeed, you can do that, and you will do that if you take each of their problems. I often say to patients, look, we'll do this. This is plan A, but don't worry, I've got a plan B and I've got a plan C. Sometimes you go to plan B and you go to plan C and you have to think again, but you can always find a plan D. But if you are hopeless about their situation, then you push them in the direction of despair. And I'm not talking about false hope. I'm talking about realistic hope. So what about this desire for death? Well, let me just give you a quote from a woman. An old woman, 88, at the end of her life, in bed and unable to do, but able to receive and find an unexpected serenity in receiving. This was 4 years after she wanted someone to give her lethal drugs to end her life. And as she said, a week ago, my wish to die resurfaced, yet my ability to live resurfaced too. People fluctuate in their desire for death. They're vulnerable, and that's why you can steer them on that bicycle either one way or the other, because they're looking for cues, directions to go in. When we talk about so-called assisted dying, what are we talking about? Well, we're talking about euthanasia, physician-assisted suicide, or where the doctor isn't involved, then just assisted suicide. There is compassion and morality on both sides of the debate. Let me go back for a moment to this and explain to you. Euthanasia is where you inject drugs, lethal drugs, intravenously. You give a large dose, possibly of midazolam, followed by a massive dose, several grams of phenobarbital. The idea being that the person dies rapidly. You intend to kill the person on the end of the needle. In some jurisdictions, they also add curare, which of course means the person can't move a muscle and they die of asphyxia. In physician-assisted suicide, the doctor provides the lethal drugs that the patient takes themselves. It may be several grams of barbiturate. Now, in some parts of the world where barbiturates are not available, they're using rather strange mixtures. They're all in the Oregon Health Department reports. The idea is to give these drugs to induce a cardiac arrhythmia and cause a cardiac arrest. And then with assisted suicide, there are various toxic substances that people have bought on the internet or been steered to on the internet. This hasn't been their doctor, somebody else has steered them towards how to commit suicide. So there is compassion on both sides. People want to avoid bad deaths, but the real debate is if you change the law, how safe is it? And do safeguards work? And are the safeguards proportionate to the risk? Are they realistic? And do they work in the real world, in the difficult, complex circumstances of the real world? Now, one of the things in the safeguards that people talk about is capacity, mental capacity. If you're going to take the decision to end your life, you must have accurate information. You must have the mental capacity to take the biggest decision that you could take, which is to end your life. And it must be free of pressure and coercion. And I'll deal with those three things now. So what about capacity? Well, the bigger the decision, the greater the mental capacity you need. And of course, the fact that you have mental capacity now doesn't mean that you'll have it in the future. Or the fact that you had delirium and lacked it previously doesn't mean that you don't have it now. It is time specific and decision specific. As I said, you need accurate information, capacity to take the decision, and it must be voluntary. That applies to any decision that you take. You should never be coerced, pressurized into a decision. It's not a valid decision if you've been pressurized. People talk a lot about autonomy, being able to make a choice. Well, you have to be able to communicate it as well. But your autonomy only exists if it's respected. But importantly, the autonomy of one person cannot override the autonomy of another. There is no hierarchy in autonomy. A person cannot tell you to do something that you do not want to do, that you do not feel is right to do. The autonomous wish of a patient might be in conflict with the autonomy of others in their family, or it might be that they're wanting something that the clinician cannot, for very valid reason, or does not wish to provide. When you assess capacity, it's important to know whether there's a disorder of the mind or brain, but in particular, whether it's interfering in the person's thinking. And can they understand and retain the information they're told? Now, obviously, for the biggest decision that you could take, that has to be pretty well intact. And can they weigh up the information and understand the implications for themselves and for others? And that's really important. You often find that people appear to be completely compos mentis, as if they understand, but then when you ask them what they see as the implications for themselves or for other people, you realize that actually they don't really understand the issue at all, and they don't have capacity for it. And obviously they have to be able to communicate their decision as well. So, as I said, decision-making is time and decision specific. I just wanted to show you this young lady to illustrate, though, things aren't straightforward. She was the victim of a hit and run accident. And she describes herself when she was in intensive care with a profound head injury as being a bit like this model that she made with spaghetti brain, with her brain all mangled up and coming out. She was a very high achieving academic scholar. And now she has to function at a completely different level because of the head injury that she sustained. And during COVID, she saw new threats coming, and this was a piece of her artwork during COVID. She's called Grace Curry, and she's got a website with her artwork on it, and it's really very powerful. And when coronavirus came along and there were issues around deprivation of liberty safeguards, that's what DOL stands for, her comment was, just keep calm and carry on, as COVID came and was a threat to everyone. Some people don't have literacy skills. They need help to understand things. And I don't know whether any of you have seen these books, Beyond Words. These are ways to help people understand some of the decisions that they have to make. This one is about having chemotherapy for cancer and what would be involved, and making decisions about having treatment. There are lots of tools available to support people to make their own decisions or in decision making in general. But when you're going to be supporting somebody, such as Grace being supported, not only do they need the information and know the options, but they need it in a way that they can cope with and understand. There's no point giving Grace an information leaflet because she can't manage that now. But if you show her photographs and talk to her and explain it, she can understand and take things in. So it's really important as well to use people's strengths in decision making. Think about what they can do well, what supports them to make decisions. And only when that's failed, move into a formal assessment of capacity. Assessing capacity is not a tick box quiz. It is not like a mini mental state. That's not enough. In the UK, we have the Mental Capacity Act, which says if someone can't make a decision for themselves, a decision must be made in their best interest. But I put this in to draw to your attention that if it's life-sustaining treatment, the decision must not be motivated by a desire to bring around the person's death. So you can't say, well, this person would be better off dead. You might say, this treatment is not achieving anything and has become futile. It lacks benefit, but you can't be motivated to bring about their death. You can't be motivated that if they were dead, life would be easier for other people and it would clear the hospital bed or whatever. No, that is against the law. Yeah. And if you're taking a decision on behalf of somebody else, you need to try to think into their shoes. Will they get capacity back again for decisions? What were their wishes and feelings and values and beliefs? And still involve them and encourage their participation. I put in red at the bottom of this slide that stopping hydration and nutrition, because people often talk about stopping them as if they are one thing, but they're not. It may well be that parenteral nutrition has become burdensome for somebody. It may be that there's a decision to not go to parenteral nutrition when perhaps gastrostomy or duodenostomy have failed. But that's different to stopping hydration. Somebody may still benefit from subcutaneous fluids running to stop them being uncomfortably dry as they're dying naturally of their underlying disease. So I would ask you, when you're discussing this, to uncouple them, because being dehydrated is horrid and very uncomfortable. People can live for quite a long time without nutrition, though. And when you're communicating with people, think about unconscious bias that you might have. If somebody says to you, "This is terrible, I wish I was dead," what is your own unconscious bias? How do you feel about that? Do you know the person? Do you know about them enough to make decisions? And are you listening actively? I'm afraid doctors are not very good at listening actively. All too often they talk rather than listen. You should listen for at least 80% of the time. And if you're on the person's territory, if you're in their own home, or in an environment which they feel in control of, you'll get far more information than if you've got them sitting in front of you in an outpatient clinic. But when you're listening, please remember that listening isn't only your ears. This is the Chinese symbol for listening. You listen with your eyes, you listen with your undivided attention. You use your mind to think about all the inputs that you have. And above all, that you listen with your heart. People know if you're listening sincerely and that you're caring about them. So I said about taking decisions in the person's best interest. The hand is up there because that we have 5 principles in our Mental Capacity Act in the UK. I don't think many other countries have got a Mental Capacity Act that's quite as well worked out as ours. But it does require us to encourage participation, to know the person's views, and people can refuse treatment in advance. They can say they do not want cardiopulmonary resuscitation, but it must be very specific to the situation. And as I said, if it's life-sustaining, you cannot make assumptions about the person's quality of life, and you mustn't be motivated to bring about their death. So there are 4 steps really involved in if you're taking difficult decisions, particularly towards the end of life. You need to think, what is really in the person's best interest? Who is the decision maker here? Who is the one? And is there a legal framework, such as a legal attorney, a power of attorney, or a court-appointed deputy? Is there some advanced decision to refuse treatment written down by someone? And who is being consulted? Have you asked the people in the family, other people who know this person and know what they might want to do? And of course, you can only consider what's possible. If something isn't available, it can't be considered in a decision making. But when you talk about someone's best interest, remember they have no interest when they're dead. They have interests when they're alive. When they're dead, they're a corpse. That's it. For every decision, we weigh things up. We weigh up the risks and the burdens against the benefits. It is a balance. And for every decision, it needs consent from the patient for every intervention. So what are some of the pitfalls in end-of-life decision-making? Well, I've put them here, and the problem is that people have put so-called safeguards in place over euthanasia that really don't adequately recognise these. And they are issues around the accuracy of the diagnosis. We know that diagnosis is often not correct. Prognosis, we cannot predict prognosis. 6 months is absolutely hopeless. I told you about the lady who 4 years before had wanted euthanasia. At the time that happened, her prognosis was estimated to be about 6 to 8 weeks. But there she was alive 4 years later. We're no good at detecting coercion. We don't detect what goes on behind closed doors. And then people could make an advanced decision to refuse treatment or an advanced statement. That's care planning. Planning in advance is a statement of someone's wishes for the future. So what about the accuracy of being terminally ill? Well, postmortems, I was on a select committee, and we were told by the College of Pathologists that in 30% there was an error in the medically certified cause of death. And in 1 in 20, there was a misdiagnosis of terminal illness. We are not always correct with our diagnosis. And as for a prognosis, we are pretty hopeless. If you think death is 6 to 8 months away, we're pretty desperately hopeless. There was the Liverpool Care Pathway, which was thought to predict when people were in the last 72 hours of life. And they found that even in the last 48 hours, as estimated, 3% of people improve. We cannot predict prognosis. All I know now when I'm asked about prognosis is all I can say is, I'm sorry. I wish I could tell you, but I don't know. It would make it easier for you, and it would make it easier for me if I could predict, but I can't. So perhaps we need to plan for the worst and hope for the best. And that ability to make decisions, it can be seriously impaired by things like motor neuron disease, or ALS, it's called in many parts of the world. Parkinson's disease impairs about 30% of people's cognitive function. Multiple sclerosis is higher. And of course, drugs, metabolic changes, depression, and hopelessness are all mutually reinforcing. They all impair your ability to make decisions. But the one that worries me most of all is our complete inability to detect what goes on behind closed doors. As I said, people's wish to live and to die fluctuates internally. People are frightened of being a burden on the family, but we don't know what goes on in families behind closed doors. We don't know about financial pressures. We don't know about the person who's made to feel that they have no place or no role, that they're a burden. And of course, don't forget the power differential between a patient and a doctor. Do people have a clear and settled intention to end their life, or are they being pushed down that route? The problem with changing the law for euthanasia or assisted suicide is that you, the doctor, carry legal responsibility for saying that there is no coercion, that there are no pressures, that this is a clear and settled intention. I just don't think you can say that with certainty. So what are the roles of doctors? Well, the role of the doctor has been to try to save and maintain life while accepting the inevitability of death, to give all comfort when people are dying and support people in the context of their family. And we have crucial roles in suicide prevention and public health. So it becomes very conflicting if we suddenly cut a hole in suicide prevention policies and say, we're working to prevent suicide, and all these people, but all of a sudden there's another group of people and we'll help them commit suicide. We'll help them end their lives. It doesn't feel logical or safe. I explained to you, physician-assisted suicide is either a massive overdose of a drug such as a barbiturate, or injecting euthanasia, a short-acting anesthetic agent, and possibly curare. Oh, I've already covered that, sorry. I would remind you here, having gone through those issues, that when we stop an intervention, such as taking someone off a ventilator, we must provide them with all care until they die, keep them well symptom controlled. We know how to do it. We have kept them alive for longer than they would have otherwise lived. They would have died, and they now die of their disease, that underlying condition. That is not euthanasia. Don't let anybody tell you that's euthanasia. This, I would remind you, is euthanasia. You're giving lethal drugs deliberately to bring about death later on. I've written a book about it and the complexities, and you can get it on the Amazon website. You can download it as a reader as well. And it goes through these different issues in depth, chapter by chapter. We've written it as something quite easy to read. It's quite a small book, and hope that you might find it helpful. What happens when you do change the law, though? What's happened in the countries that have changed the law? Well, nobody should think the numbers are small. They go up and up and up, as you can see on all these graphs. And we know that now in Belgium, about 40% aren't reported. In Canada, the deaths are going up very, very fast from euthanasia in particular. So something changes in society, something changes in the relationship of doctors to patients. And I've had conversations with doctors in Belgium in particular, where they feel that it's gone out of control. They're under pressure by families to end life. They feel under pressure. They don't really want to be the executioner, but they feel that they've got no option somehow. And in Canada, certainly the palliative care services are dwindling, because this is becoming a default way of at the end of life and ending life, rather than supporting people when they're dying. In Oregon, they only have physician-assisted suicide. They publish their data. It's fairly well collated, and it's on the Oregon Health website if any of you are interested in looking at their annual reports. What about some of the other people who we deal with, young people? Well, there's real difficulty then when people move from young person services to adult services. And the gap in services, they move from pediatric services to adult services, is huge and makes things really difficult. And patient groups and staff have told me that they find there's a very poor understanding of issues around mental capacity, the Mental Capacity Act. And DOLS is legislation we have over deprivation of liberty. So if somebody is being detained in a place of care, it must be legally sanctioned. It must be signed off as legally holding them in a place of safety, in a place of care. But there are real difficulties over independence from parents. We need to plan ahead for people, and for young people, we need to plan ahead as they transition to different services. But as a golden rule, and this came from a poster that was done in one of the hospitals in London for their emergency department, because of all the problems of COVID, just keep the patient at the center of all you do. If you keep the patient at the center of your thinking, that is your priority, to look after them, then you'll find it easier, and you'll find it easier to resist those pressures. Some people say, well, you know, there are people having horrible deaths, dying badly. It's some very nasty cancers, nasty neurological diseases. The problem is that we don't only look after just the person in front of us. We have a duty across society. And as somebody said, in a world of idealized, wholly autonomous patients and wholly selfless and compassionate families and professionals, legalization provided for assisted dying, that's either assisted suicide or euthanasia, might, if ethically acceptable, not be risky. But we do not live in that world, and we should not put too much weight on the fragile structure of the voluntary. Going back to the point I made about coercion, we don't know what goes on behind closed doors. We can't rely on it. Thank you. And I'm very happy to take questions from anyone.
Well, thank you so much, ma'am. That was a very nice session. I hope everyone, they enjoyed the session. And now we keep the session open for questions. Are there any questions?
Anyone would like to pop them? I think we've just got a chat function, haven't we? Not a Q&A. So do put any questions in the chat. And one of the things I was wondering about is how often you find that people accuse you of ending life when you're involved in difficult decisions to stop treatment, which is not being successful. Perhaps some of you might have come across that situation either in intensive care or particularly now with the pressures of COVID.
Ma'am, can you repeat the question?
I was wondering whether people have had difficult situations, particularly in COVID. I see that Sarang B has got a hand up. So can we go to Sarang B?
Yeah, hello, ma'am. I have a question for you.
Thank you.
You just said that in Belgium, the rate of assisted dying has gone up. So for a country like India, where we have a lot of population, a lot of dependent population, won't it be a step back if we start getting a lot of cases where we have to assist in dying? For example, New Zealand just I think 2 days ago, they decided to legalize assisted dying. But in case of India, where we have a lot of population which is dependent, don't you think it would be hard for us to go into that direction?
I would agree with you. Is it Dr. Sarang?
Yeah, ma'am.
Yeah. I would agree with you. I think it would be extremely dangerous. I think it would be I think it would be impossible to police it. I think it would be impossible to make sure that that things were done properly and carefully. And even if you look at the evidence from Belgium, that's why I highlighted it, because if 40% there are now not being properly reported, I think in India it would result in the most terrible chaos, judgments being made over people's lives, and I dread to think what would happen to medical practice. I would agree with you. I think it would be terribly dangerous because you have many areas of really quite inadequate provision. You have some centres of excellence, but you also have enormous pressures on your health service and enormous pressures on the way the whole population is organised.
Thank you, ma'am.
Thank you. I really agree with you very strongly, actually. Dr. Devyani, would you like to put your question?
Hello, ma'am.
Hello.
Am I audible?
Yes, excellent.
First of all, ma'am, I would really like to thank you for taking such an elaborate and wonderful discussion on this topic, which I think was really needed at this time of the year, like, the COVID times, especially in a country like India, we definitely needed to have some sort of insight into this topic. What I would like to share and maybe pose the question to you is that, as you said, in the COVID time, we've seen we have had, like, I have been posted in the critical ICUs. So we got a lot of patients where we would be like, we were at most confident that we might be able to save the patient, but we had relatives and family members who have persuaded us to, just stop the procedure. And those things were probably because of two main reasons: financial constraints, and there's no caretaker in the family. So I would want to ask you that in such a critical time, when it is not totally upon the clinician, most of the judgments are based on the family members, the financial decisions, probably how many members are available in the family, and they tend to take up such drastic steps that sometimes we are at a loss. Like, what are we supposed to tell to the patient's family, and how are we supposed to deal with such situations?
Thank you very much, Dr. Devyani, and thank you for bringing the voice of reality into the discussion, because your experience, I think, has been the experience of many, many doctors around the world, where you might learn something in theory and you know what you feel you ought to do, but there are an enormous number of pressures on you, and you really find it difficult to work out what is the best for that person. And also you have all the other patients that you have to look after as well. And you have a clinical team that you're working with who are also under enormous pressure and often exhausted. And I think, sadly, I wish there was a simple answer, a straightforward answer, but I don't think there is. And I would commend you and congratulate you for having the wisdom and insight to look beyond what you're first being told and realizing that this burden of decision sits on your shoulders, and that it's really difficult to weigh it up. I think when you are weighing things up, sometimes it's helpful to just try to stand back from all of these emotional pressures and all the people who are talking to you and telling you all kinds of things, and just look at the patient in front of you and try to work out from the information that you've got clinically, are they actually going to survive and potentially improve, particularly with something like COVID? Or are they actually dying? And is this an irreversible path to death? Is it that things are now closing down? And if you can, in a way, shed some of those pressures, put them to the side, then you can look at that clinical situation, and then you can go back and let those other influences come in. Because quite often you will have a patient in front of you and you think, I just don't think this person is going to do well. Or you have somebody in front of you and you think, actually, I think they could improve and they could get back to where they were before and not be dependent. But there are a lot of people coming without that degree of experience that you have and trying to pressurize you one way or another into making a decision. And that's really, really difficult. And in a system where people are also paying for their healthcare, I have to say, I don't envy you, because I think it makes it even more difficult. But thank you for raising it. And I would encourage you to carry on having the insight and wisdom to look at each decision carefully, as you clearly have done.
Thank you so much, ma'am. Thank you so much.
And is it Dr. Rana? Is Is it Dr. Rana or Dr. Yuvraj?
Hello.
Hello, is it Dr. Rana?
Ma'am, am I audible?
Yes, you are. Thank you.
Ma'am, I have a question. Ma'am, what are your thoughts about families that those have children with special needs? You know, with special, well, euthanasia.
Okay.
The thoughts for euthanasia.
Right. I think that you must never take a eugenics approach. You must never say that one person's life is more valuable than another. You just don't know. Each life is of value. Each life is of worth. When you start to go down the route of thinking that some lives are not worth living, that eugenics approach was what happened with the Nazis in Germany before the Second World War. There are some countries in the world where I think there is murder of people with learning difficulties and with physical difficulties. And I hope none of you are any part of any of that, and that you would stand up for the right of somebody to have the support and care that they need. Of course, people will die. Everybody will die. Every one of us will die. Sometimes it's difficult for us to think about our own mortality. But we must never abandon our role as physicians in terms of supporting people. I'm really grateful to you for asking the question, because it's a question that a lot of people have at the back of their mind, but don't have the courage to ask. And I think you have to be very, very careful that unconscious bias and inappropriate value judgments don't creep in to people's thinking.
Ma'am, what if the family wants? Ma'am, what if the family itself wants euthanasia?
That is not for you to do. That is not for you to be a murderer. That is not for you to plan killing a child. The family may be exhausted. The family may need more support. The family may need your help to look at how they can provide for the needs of the person. And I think you also remember that sometimes the families will say that because it's a cry for help. It's a way of telling you how desperate they are for help and support. And that they may need a completely different, they may need help and support. They may need some respite, if you can arrange it, of somebody else looking after the child for a time. And of course, as the children get older, things become more difficult. But very often these children, their life expectancy isn't as long anyway, because other things happen to them on the way. And there you are balancing up how much you actively intervene, how much you are vigorous in your intervention. And you always have to say, is this helping or is this making the condition worse for the individual? But never be pressurized into ending a life. Never be pressurized into it, because you'll never forgive yourself later on, quite apart from it being illegal. But there is that internal moral code that you must know that you have valued each person and you've done what's right for the individual in front of you. But where the families are pressurizing you, I do think it's worth asking and exploring it a bit, because it may well be a cry for help.
Okay, so my first responsibility would be to educate the family first. And
I think your first responsibility would be to say, why do you ask? What are the problems? So look for it. It isn't that you educate them. Explore, ask. You just use questions to get the information. Why do you ask? What is it that's making things so difficult? What is the most difficult thing at the moment? How do you see things going in the future? Where do you see the biggest problems? Keep getting information, and as you get more and more information, it will become clear. You can't tell them what to do because you don't know what the situation is like, but you can find out about the situation.
Ma'am, what if it is a financial issue?
Well, I'm not. Are you in India?
Yes, ma'am.
Okay. I mean, I don't know what your different what's available to you in terms of benefits. You don't have a welfare system like we have in the UK, I know.
Yes, ma'am.
But you aren't responsible. It is not your fault that people are poor. It is not your fault that the state does not provide enough support for them. But what you can do is then help them look at whether there are other places that they could get some help and support from, and whether there are other ways that they could approach their situation. And that might be difficult, but don't, you know, you're not God. You're not a God. You don't have the power to wave a magic wand and solve the problem. And it may be that they need to be put in touch with the charity somewhere that would provide them with some help and support, or put them in touch with somebody who could provide them with better advice and spend more time with them. People often come to the doctor when they don't know where to go, but it doesn't always mean the doctor's the best person for them to talk to.
Yes, ma'am. Okay, thank you very much.
Thank you. I think Dr. Yadav, is it Akshay Yadav had a hand up and now it's gone down?
Yeah, ma'am, actually, the same question which he asked later on, that what if the financial condition is not good? Because I myself, when I'm posted in ICU duties, and when few relatives themselves come and say that we can't afford this. So at that time, what is to be done? But then you have answered it, ma'am. So that is why I lowered my hand.
Yeah, thank you. Thank you.
I think a few more questions are there.
Yes,
no, I think
Sarang.
we have. No, Sarang has raised his hand again.
Okay.
Sarang?
Yeah, ma'am. Ma'am, we had a very famous case in India a few years back. The patient was on assisted ventilation for years together. And in the end, the Supreme Court had to step in. Some other people had to step in. So my question is, in a case where the patient is not in a position to take the decision and he does not have a family, how much appropriate will it be for a committee to make that decision for him or for her?
Okay. I think when you're looking at somebody where there is no family and they're being ventilated, when you start ventilation, you begin because you think it will make the situation better. When it's clear that it is not achieving any improvement and things are deteriorating, then you are left with having to ask yourself whether you should carry on or whether it has now become futile, and whether being ventilated is more of a burden than to come off ventilation and accept that the person will die of the original condition that meant they went on a ventilator in the first place. The disease process that stopped them breathing has not improved by your actions. And therefore, you have to think again. Now, it may be when that happens that you decide that, in fact, this is futile, this is not achieving anything at all, it is just distressing for the patient. I think in that situation, though, I would always try to get some legal advice and legal support. Don't take the decision on your own shoulders or into your own hands, because somebody may well turn around and make accusations against you. So you might actually benefit from having a court order if there is nobody else to share the decision with.
Okay, thank you, ma'am.
Thank you so much, ma'am. All the questions I think were very beautifully answered by you. And if there are no more questions, so I think we can conclude the session.
Thank you. I'm sorry that at the beginning I was a bit of time. I couldn't, as you all know, I couldn't log on initially. The system told me that it was a corrupt link, but thank you for making it work later on. And thank you all for joining and listening. And I hope that you found that it was helpful in your thinking. And I would congratulate all of you for studying and thinking. That's the most important thing you can do for your own long-term development. Thank you.
Yeah, definitely, ma'am. It was very helpful to all of us. And at the same time, I would like to invite you all for the inauguration ceremony tomorrow of Ethos. With this, the pre-conference workshops have concluded, and this was the last session and last slot today. And it was a tiring day, definitely, but then we invite you all tomorrow morning at 8 a.m. IST, when we will start with the inauguration ceremony of Ethos 2021. And it will be a 4-day long event, and we will share the links to join the session 1 day prior each day, so that there are no more confusions. And we thank wholeheartedly to you, ma'am. Thank you so much for this session, and we all enjoyed it, definitely. Thank you.
Thank you very much indeed. Thank you.